the patient outcome, and that's why they should be dealt, and they should be understood, and they should be they should be really followed up very closely. And because unless you know these infections, you will not be able to manage them or protect them or prophylactically take care of them, and once happen, how to treat them. So this, it's a long lecture, but I will skip the unnecessary slides, and I will concentrate on the major ones, and then we'll see if you have any question, and if you have any time we can discuss. So as it says that these surgeons encounter the infections in two ways basically. Either the patient present with an infection that requires surgical treatment, that is drainage of an abscess for example, or infection that happens as a complication to any surgical procedure, that like a wound infection. So these are the host defense system or host defense mechanism which prevent any individual from having or contacting any infection. There are physical barriers, there are biochemical and humoral factors, and there are cellular factors. And you know the physical barriers are the skin, the mucous membrane, the cilia, the gastric hydrochloric acid, the tears itself, the urine, the sweat glands, the sweat itself from the sweat glands, and acute phase proteins, and the complement fixation system, antibodies and interferons. And the cellular, we have the neutrophils, the macrophages, the natural killer cell, B lymphocytes, and the T lymphocyte. These are the normal defense host system. So what is an infection? Infection is a micro. So you have the lecture already with you. So the microorganisms in the host tissue. What is infection? Infection is basically the organism, the microorganism which are in a patient's tissue or in the bloodstream with an inflammatory response, which is very important to understand. What is this inflammatory response? Okay, what are the mechanism manifestation of infection? You know, you must have read in your pathology the local inflammatory signs: the rubor, the calor, the delor, the tumor, and the functio lisa. These are the other words for the redness, heat, color, swelling, and function and loss of function. These are the Greek words used for inflammation. Okay, what is the systemic manifestation? It is called systemic inflammatory response syndrome. And what is SIRS? This is the word that you will be hearing a lot when you go into the practice with patients going into complications. That what is SIRS? SIRS. It is called SIRS, and it means that either two or more of the following criteria should be fulfilled. If these two or more criteria are fulfilled, then patient is supposed to have the SIRS, which is temperature less than 36 or more than 38, heart rate more than 90, respiratory rate of more than 20, and a WBC or a white blood cell count less than 4,000 or more than 12,000. So if any out of these four, out of these four, if present, it is said that the patient has SIRS. And what is sepsis? Sepsis means SIRS plus evidence of local or systemic infection. If you go to the previous slide, it does not say anything about the local presentation or local presentation of the infection. It says the systemic presentation, which is the temperature, the heart rate, the respiratory rate, and the white cell count. And the sepsis is SIRS plus evidence of local or systemic infection, meaning there is redness, meaning there is a loss of there's the hypotension. These are the systemic, and the local we just said that there is redness, there is swelling, there is pain, there is loss of function. And what is septic shock? These are three similar terms: SIRS, sepsis, and septic shock, which you should be able to differentiate the three. And septic shock is sepsis plus organ dysfunction. I mean to say that there is either, when the patient goes into sepsis, you know that there can be renal compromise, there can be pulmonary compromise, there can be cardiac compromise. So these are the various, or the neurological compromise. These are other systems of the body that gets affected because of the sepsis. When other organ gets dysfunction, like when the renal functions are deteriorated, So that means the patient is in septic shock. Okay, the classification, it is called acute and subacute and chronic. So the word itself tells us a lot about the what is acute. So I don't want to go into the detail. So pathology, this is also nothing important here. Okay, now specific type of infection, which are not this tuberculosis is actually not a surgical infection. Yes, tetanus can be a surgical infection, and gas gangrene can be a surgical infection. Tuberculosis is one of the specific, it comes under the heading of systemic infection, specific infection, but is actually not related to the surgery. So how do we diagnose these infections? Either they have systemic manifestation, local manifestation, organic dysfunction, or specific expression. Labs, you know that ultrasound, X-ray, CT, and the complete blood count and the acute phase proteins reactants will also tell us about this. So what is the management of infection? If it is abscess, it needs drainage, it may need only dressing, it may need a local care, it may also need antibiotic. We'll come to this topic of the role of antibiotic in a little while, which is supposed to be the most important part of this lecture. All right. So you will hear me concentrating more on the role of antibiotics in surgery rather than the rest of the less important topics. Okay, just for the sake of definition, you should know what is a boil. Boil is a furuncle. It is also called furuncle. It is the infection of the hair follicle or a sebaceous gland in our skin, which is infection of one boil. One hair follicle is infected, it presents as a furuncle or a boil. And this is usually caused by staphylococcus. When a boil is formed, meaning a small pocket of pus, very small, less like a dot, it is treated by a puncture or by incision and drainage and better hygiene, and systemic antibiotics are usually not required in such cases. Okay, and furunculosis is called when infection of several hair follicles in a specific area is involved. You can see that this on the next picture, that what it looks like, a furuncle. How does it look like? A small abscess. And this is furunculosis. You see the difference between furuncle and furunculosis. Furunculosis is multiple furuncles in a specific area. Okay, this carbuncle. This carbuncle is one of the very important surgical diagnosis of infection. Usually it is seen in diabetic patients, usually in the back of the back, at the nape of the back or the back of the upper back. All right, so this is usually seen, and you can see the difference between a furunculosis or furuncle from a carbuncle. You can see in a carbuncle there are multiple discharging points. This is not a very good representative picture of carbuncle, but there are multiple. You may see at least 20 to 25 or more than 25 small discharging sinuses. This is a carbuncle which is very typical for patients who are diabetic, and this also needs incision and excision of the pathology along with cover of antibiotics. Cellulitis, which is one of the most common infection of the subcutaneous tissue. When you see a red skin, that is actually cellulitis. It is caused usually by the Streptococcus pyogenes. The microorganism is called Streptococcus pyogenes, and the anaerobic one is called the Meniere's gangrene. Okay, two clinical syndromes in this type of infection are seen: progressive bacterial synergistic gangrene, penoscrotal lesion. And this we are talking about the anaerobic cellulitis, which is called Fournier's gangrene, or the next one is necrotizing fasciitis. Okay, so these are special type of gangrenous infection of the soft tissue or of the skin, subcutaneous tissue. This is what we call cellulitis, the red discoloration of the skin. Okay, erysipelas. How is erysipelas different from cellulitis? Erysipelas has a raised edge, has a raised margin. Cellulitis does not have a is not a raised margin. It is also red. Erysipelas is as red as the cellulitis. But the difference, the differentiating point is that the erysipelas has a raised margin as compared to the cellulitis. And both are called by and this one is erysipelas is caused by the streptococcus, beta hemolytic streptococcus, whereas the cellulitis is caused by staphylococcus. Okay, sorry, this is called the streptococcus pyogenes, which is causing the cellulitis, and the erysipelas is caused by beta hemolytic streptococcus. Okay, now this is the abscess, which is one of the common conditions for both of the dental and the surgical, the general surgical specialities, that you can encounter abscess, which is usually formed by Staphylococcus aureus infection, and it usually needs treatment in the form of incision and drainage, and may need antibiotic or may not need antibiotic. These are the various infections. The abscesses you can see on the foot, the breast abscess, and there's a abscess on the shoulder, and this one on in the thigh, which has been aspirated, the left lower part. This is the one which is showing aspiration of an abscess through a syringe, closed aspiration. Okay, hidradenitis suppurativa is an infection of the apocrine glands in the skin. It is common in the axilla and the groin. It is usually seen in the armpits and the groin area. And these are again very difficult infection to treat. And these are again multiple tender swellings under the arm or in the groin. And if the treatment is excision, and the area should be kept. You should know the difference between incision and excision. Excision is complete removal of the tissue, and incision is just giving a cut. Okay, this is how necrotizing soft tissue infection looks like. It is the gangrene of the superficial skin only. It is not the gangrene of the whole limb. You know, when the gangrene, there is a gangrene of the whole limb, the whole tissue, the bones, the subcutaneous tissue, the muscle, they all get gangrenous. But in a necrotizing soft tissue infection, it is the gangrene of the superficial skin or the soft tissue only. It is not the gangrene of the bones and the muscles. And this is caused by Clostridium, group A, Streptococcus, and polymicrobial. And it needs it's a true surgical emergency which needs debridement, thorough debridement, and antibiotics. Okay, now wound infection. Why does wound infection happen? Why does wound infection happen in any patient? Okay, what are the factors which lead towards wound infection? Either these causes are either endogenous, meaning related to the patient, or exogenous, related to the surrounding of the patient, which can be the operating room, which can be the operating instruments, which can be the operating surgeons, and the endogenous is related to the patient himself. Okay, now what are the predisposing factors? There's a poor blood supply of that region, there's poor surgical technique, there's a foreign body placed there, there's poor sterilization, nature of operation, there's wound hematoma, and there's a high bacterial load. And what are the predisposing factors? General, if it is the aging, if it is a patient is aging, is an old age patient, so the immunity is less, so the chances of wound infection are more. There's a poor, if the general condition or the hygiene is poor, then there's more chances of wound infection. There are systemic diseases like diabetes, like malignancies, like renal failure, that will predispose to wound infections. And if the patient is on immunosuppressive drugs. Okay, factors influencing the systemic infections. This is the type of the procedure, the degree of the contamination, the duration of the operation, the urgency of the operation, the skin preparation. So here we see that it depends on what type of procedure we are doing, what is the degree of contamination, and what is how long is the duration of surgery. If it is longer, then there are more chances of infection. If it is an urgent procedure being performed in an emergency situation, the chances of infection is always more than an elective procedure. Whether the skin is properly prepared or not with pyodine and chlorhexidine, and what is the operating environment like, and has the patient received the antibiotic prophylaxis or not. Okay, now as we have discussed before also, the clinical picture of wound infection is that generally there is a patient who has fever, there is pain in the wound, there is wound swelling, there is tenderness, there is redness and fluctuation of crepitus. Prophylaxis against wound infection, you have to have a good pre-operative preparation. Prophylactic antibiotics is in clean, contaminated or contaminated. I will come to this line. Okay, just a minute. Give me 1 second. Just give me 1 second.
Yes, yes, doctor.
Okay. Okay. Once we discontinue, I'll rejoin. Okay. So I'm very fast. I know that, and I'm also sure you are not following a lot. But I will come to the main part now. Now this is a general concept among all the health workers, that when a patient is going under surgery, all right, when a patient is undergoing any surgery, they should receive antibiotic. They should receive antibiotic as a prophylaxis, and they should be continued on antibiotic for some period of time, meaning 3 days or 5 days. This is a general misconception. Okay, I'm saying misconception. Not all patients will require antibiotics. Why do I say that? I say this because the studies have proven that when a surgery is a clean surgery, you don't need antibiotics, because the chance of infection is very, very low, less than 2%. So you don't want to put every patient on antibiotic, so the resistance will increase over the time, and that's why the infection, the antibiotics are reserved for special cases. Okay, so what are those cases? What do you understand by the word clean surgery, and what do you understand by the word clean contaminated surgery? What do you understand by the word contaminated surgery? So this is something I would like to go into more detail, because this decides whether the patient needs any surgery, when any antibiotics or not. Okay. Okay. Now this is a picture, not a very good one, but okay. If you understand now, try to understand what I'm trying to say now. What is a clean surgery? Clean surgery is a surgery when it is an elective surgery, it is a scheduled surgery. Okay, and there is no infection pre-operatively present. Okay, now actually, and there is no break in the asepsis, meaning there is no problem with the instruments in the theater. They are all aseptically cleaned and autoclaved or sterilized. Okay, now the last line, if you can read that: respiratory, alimentary, genitourinary or oropharyngeal tracts are not entered. Now this is the most important part to understand what is clean surgery. When I say this, that when the mucosa of the respiratory tract, when the mucosa of the alimentary tract, when the mucosa of the genitourinary tract, when the mucosa of the oropharyngeal tract is not breached, unless you enter into a hollow cavity. You all know that the gut, the GIT, is made of a serosa. Okay, serosa, then muscularis mucosa, muscularis, then muscularis mucosa, then the submucosa, then the mucosa, from outside to inside. So if during a surgery you cut a bowel, you cut a small intestine, you cut a large intestine, so that surgery will automatically become, it will not be a clean surgery. As long as you are not cutting into the mucosa, it is called a clean surgery. Osama and others, is it clear to you, or you want me to tell you more about it? Because this is important. Now I want to concentrate more on this, because this is the role of antibiotics in surgery. Should I repeat, Osama?
Yes, doctor, please. If you can.
Okay. Okay, you can imagine the trachea, you can imagine the lung, the tracheal tree, you can imagine the esophagus, you can imagine the stomach. Can you? Can you? You know what a stomach is like, what a small intestine is like. You have an idea or not?
Yes, yes.
Okay. So the intestine, they have multiple layers, and the most inside layer is called the mucosa. So if I am cutting the intestine, but I'm stopping before the mucosa I cut. It is called a clean surgery. The moment I cut the mucosa, it will change into clean contaminated surgery. And number 3 is the contaminated surgery, meaning we already know that there is pus inside the cavity. Okay, so this is already a contaminated surgery. And the 4th one is a dirty surgery. Dirty surgery means there is a road traffic accident on the road, and there is dirt attached to the wound. There is lot of dirty material, foreign particles attached to the wound. So that is called a dirty surgery. Okay, now why are we calling this clean or clean contaminated or contaminated surgery? Because we want to choose whether we have to give antibiotic or not. So if we are doing a surgery where we anticipate that we are not going to enter into the mucosa, it is called a clean surgery. And this clean surgery, we don't need any antibiotics. We don't need any antibiotics. For example, if we are doing a surgery on the thyroid, we are not entering into the lumen of a hollow viscus. We don't need antibiotics. If we are doing a surgery on the breast lump, it does not have any luminal organ. It does not have trachea. It does not have GIT or urinary tract. So if you are doing surgery on the thyroid or on the breast or on the skin, a lipoma, a cyst, we don't need antibiotics, because according to the formula, according to the definition, clean surgeries do not need any antibiotic. But if we are breaching the mucosa, if we are entering into the mucosa, we know that if we will enter in, for example, a procedure called cholecystectomy, removal of the gallbladder. Okay, how do we remove the gallbladder? We remove the gallbladder by disconnecting it from the common bile duct with the cystic duct. Cystic duct is joining the gallbladder to the common bile duct. Okay, so if you have to divide the cystic duct to remove the gallbladder out of the body. The moment you cut the cystic duct, the surgery will be called clean contaminated surgery. And for a clean contaminated surgery, we need only prophylactic antibiotic. That means one dose pre-operatively and 2 doses post-operatively. That's all. And this is called prophylactic antibiotics, which is given in all cases of clean contaminated surgery. We know it beforehand. If we know that our surgery is something, as I said before, that our surgery is something like a thyroid surgery, which does not have a lumen, which does not have a mucosa. Our surgery is something for the breast lump. Our surgery is about a lipoma in the skin. These surgeries, we know that there is no lumen involved. So these surgeries are called clean surgeries, and clean surgeries do not need any antibiotics. Is this clear, Reham?
Yes, doctor.
And when we enter into the lumen, we know that we are going to cut the appendix to remove it. Actually, we are cutting the appendix to remove it. So we are, excuse me. So we are entering the lumen of the appendix or the hollow viscus. That means it is a clean contaminated surgery. So in a clean contaminated surgery, we give prophylactic antibiotic. Okay?
Good. Yes.
So we are giving prophylactic antibiotic only to those patients whom we know that we are going to enter the lumen. And the other thing, the third thing is called the empiric antibiotic. Empiric. One is prophylactic, one is no antibiotic, the other is prophylactic antibiotic, the third one is the empiric antibiotic. Okay, what do you mean by empiric antibiotic? Is that you continue with the antibiotic treatment for 3 days after a surgery. After 3 days, you will get the culture report of the specimen that you have sent. If the culture report tells you that there is an organism there, if the culture is positive, then you will continue with the antibiotic for 2 more days to make it a therapeutic antibiotic course. Otherwise, empiric antibiotic, if you see the report after 3 days that there is no growth, the culture is negative, then you will have to discontinue the antibiotic after 3 days. No more antibiotics if the culture is negative. But if the culture is positive, then you will have to continue for 5 days. Okay, so this was about the clean contaminated, and all contaminated surgeries mean, you know from before that there is a bowel perforation inside, because all the fecal matter, all the intestinal fluid is present in the peritoneum. You know it beforehand. So this is not clean surgery, this is not clean contaminated surgery. This is contaminated surgery. Already we know that there is perforation. So we have to continue with the antibiotic for 5 days or more. Okay?
Okay, doctor, it's clear now.
Alhamdulillah. Okay, now as I was telling you that the examples of clean surgery is like thyroid, is like breast, is like hernia repair. These are the surgeries where we know that we are not going to enter into the lumen of a hollow viscus, and the risk of infection is less than 2%. So we don't have to give antibiotics in clean surgeries. For the clean contaminated surgery, the infection rate is 5% or less. In clean contaminated surgery, as I told you, we give prophylactic antibiotic, 1 dose before the surgery and 2 more doses after the surgery. In contaminated surgery, the risk of wound infection is 15%. So the antibiotic is necessary in these cases, in all such cases. And similarly, for the dirty surgery, you will have to continue with the antibiotics. Okay, tetanus, you have heard a lot about, maybe you have heard a lot about tetanus. Whenever you get a road trauma, you will go to the emergency room, they tell you, okay, you should get your tetanus immunization. So tetanus is one of the very dreadful, very dangerous, anaerobic, gram-positive, clostridial infection, which is called Clostridium tetanum. Tetani. Clostridium tetani is the name of the organism. It can be present in the body from 1 to 20. It can present on the surface between any time between 1 to 21 days. Don't think that if you are not having such symptom, you are not infected, because it can still be there in the body for 21 days. Mode of infection is penetrating wounds contaminated by soil or road traffic accidents, traumas, umbilical stump infection. The bacteria produce their ill effects via the exotoxins. Exotoxin is composed of two elements, the neurotoxin and the hemolytic toxin. Tetanus management needs prophylaxis, which is called, if the patient is fully immunized, it is equal to the booster dose of tetanus toxoid. If the patient is fully immunized, that means booster dose of tetanus toxoid 0.5 ml is required. If a patient has not been vaccinated at all, then full course of active immunization with toxoid is recommended. Treatment for tetanus, once it happens, the treatment needs penicillins, artificial ventilation with muscle relaxation, neutralized toxin with anti-tetanic immunoglobulin. Okay, are you with me?
Yes, Dr. Rodhia.
Osama is back. MashaAllah, Osama is back. Osama is back. Okay. I cannot say that he went for a cup of tea because he must be fasting. Okay. All right. So the neutralized toxin with antiemetic immunoglobulin is also administered. Not much here. And these are this is the Clostridium tetani, which is like in the spores form, which is very dangerous. Okay, gas gangrene is another form of infection, which is also very dangerous for any patient, and similarly for the doctors also, for the surgeons also, because there is gangrene in the tissues and you have to amputate the limbs. Okay, so I will just go one by one, each slide back one by one, and I will just tell you that the slides which are important in terms of your MCQs. Okay, so you can concentrate on those slides. As for this one also, the gas gangrene is an important slide. Similarly, tetanus is also important slide. This one is just for understanding. This one is also for understanding. Okay, this slide is not really important. Okay. This you can be given that there are certain factors which are responsible for wound infections besides or except something. So you should know what are the factors which are responsible for wound infection, and the except this can be an MCQs. Okay, what are the organisms causing necrotizing soft tissue infection? Like you should know the Clostridium, Group A, Streptococcus, and polymicrobials. Okay, what is the treatment for abscess? It is incision and drainage and antibiotics. This is also very easy MCQ. Okay, I told you before the difference between the erysipelas and the cellulitis. So this can become a MCQ also. And yes, about carbuncle also, that what you may be given a description of you may be given a description of an abscess which has multiple discharging sinuses. So what the answer is, carbuncle, multiple discharging sinuses. Furunculosis, furuncle. Okay, yes. Now again, the sepsis, septic shock, and SARS. These are three important definitions you should know, because MCQs can come out of this. So that's all for the time being. Okay. Any questions?
Thank you, doctor.
Yes, Osama.
Doctor, is a removal or drainage of abscess need
Yes.
antibiotic?
Okay. Listen, the treatment for an abscess is drainage, not antibiotic. Do you understand what I said? The treatment,
Yes.
if somebody asks you what is the treatment for abscess, the answer is incision and drainage. Okay, full stop. Now the next question will be from you. Will you use antibiotic? Doctor, will you use antibiotic? The answer is no. I will not. I will use antibiotic in only special circumstances. What are the special circumstances? When the patient has localized cellulitis. If the patient has localized redness or localized infection around the abscess area. Are you getting my point? There is redness in the local area. That is one reason. Number two reason is this, that there are systemic manifestation with fever. Patient is unwell. Patient has SARS. Patient has sepsis. Patient has septic shock. These are the conditions where you will use antibiotics plus the drainage. Okay?
Yes. Thank you, doctor.
Okay.